My study was the precision of dynamic ultrasound assessment of the ulnar collateral ligament. I want to start by giving a special thanks to Harrison Goodnow, last year fellow, that really took this study off the ground, as well as the attendings Kendall and Dr. Hackel and Dr. Jordan, who are the brains behind this study, and as well as Nicole for helping out in the data collection. Start a little bit with the introduction. The ulnar collateral ligament of the elbow is a primary static restraint to valgus stress and is essential to the overhead throw in athlete's performance. We know that the anterior band of the UCL is a main stabilizer, especially as the elbow is going through range of motion from 30 to 120 degrees. Injuries to the UCL has really been described many decades ago, but the first literature was in the 1940s, described in javelin throwers. But now we know that due to the high demand of the sport of baseball, pitchers have a high susceptibility of and high risk of injuring this ulnar collateral ligament. And hopefully this video plays. We got
University of Central Florida in
powerful
Orlando.
video.
Oh! Uh-oh. No. Oh, no. Oh, no.
Not the one I've done two Tommy Johns on? I think it is.
Not sure, but this video is very powerful. First, it shows the explosiveness of what the pitch in motion is, and number two, you knew from his face something bad had happened. He knew it, the commentators knew it, the coaching staff knew it, because it is a huge problem, as Ben was stating in his presentation, and we're seeing it throughout. In Dr. Andrews' book, Any Given Monday, we're dealing with an epidemic. We're seeing it from youth baseball all the way to the major league level. As a matter of fact, baseball, MLB spends $1.5 billion a year on pitcher salary. $1.5 billion. If you combine the starting salary of every NFL quarterback, they can't even match that. Yet more than $500 million is really lost in the disabled list every single year. So it is a huge problem. When we analyze the pitch in motion and great studies that came out of ASMI with Dr. Glenn Fleisig and other researchers, we now know that in the late cock and acceleration phase is where the UCL is stressed at its maximum. Here we got a picture of Roger Clemens kind of demonstrating this particular movement, getting ready to throw a 100-mile-per-hour fastball and break Mike Piazza's bat. When patients come into clinic, when we utilize everything we do in sports medicine, history, physical exam, and imaging modality, in UCL injuries, history is usually the most important. You might come in with evidence of pain, decreased velocity, decreased performance. In the physical exam, we might have, again, point tenderness to the medial elbow. There's special testing like milking or dynamic valgus test, but really nothing very specific, nothing we could hang our hat on. When we look at imaging modalities, we know x-rays fail to visualize soft tissue, MRI, and MRA, as Ben was showing. Ben knows the gold standard when we look at classifications, but if we look at this great study performed by the musculoskeletal radiologists at Thomas Jefferson University, they looked at 88% sensitivity when we look at MRAs, but if you combine the approach with ultrasound, significantly better. So we looked at all the data that's been done on medial elbow and ultrasound of the UCL, and there's been a lot of great stuff. But when you dissect some of these studies, really they all did a little bit different. They all scanned differently. They were looking at different things. They were measuring different things. So we decided we looked at everything and we came up with the best studies, and we combined one protocol to evaluate the ulnar collateral ligament. And our hypothesis was that standardization of a dynamic ultrasound scan was going to be extremely precise in evaluating the UCL of the elbow. This was our method. In order to be statistically significant and have good power, we needed 30 skeletally mature subjects. The exams were performed by both of our primary care sports medicine physicians, who are also board certified in musculoskeletal radiology and sonography, Dr. Brett Kendall and Josh Hankel. Our inclusion criteria were straightforward. Ages from 18 to 35 that were asymptomatic. If you had an evidence of ulnar nerve subluxation, ever had surgery to the elbow, or ever had a UCL injury, we excluded you. So we pretty much wanted normal elbows, as normal as they could be. Well, I shouldn't say that because we scanned all the fellows, and as we all know, we're very far from normal. But nonetheless, we wanted normal elbows. And this is how we began our study. This was our protocol. Patients began in the lateral recumbent position with the side being evaluated, 90 degrees of shoulder flexion, and began at 30 degrees of elbow flexion. We confirmed the elbow flexion with a handheld goniometer, with one arm of the goniometer towards the acromion and the other one pointing towards the ulnar stylo, just like it's shown in the video, the picture here. We then use the linear transducer of the ultrasound probe, and we put it over the anterior band of the UCL, just like Dr. Hack was demonstrating here. And this is the image that we were looking for. This is home base for us. I'm going to start labeling some things on this ultrasound image. Right here is I highlighted the anterior band of the UCL, this nice fibrillar triangular structure originating in the medial condyle and running all the way towards his attachment at the sublunar tubercle of the ulna. A couple other things in this image just for completion. We got my flexor mass musculotendinous unit running on top, and this ulnar humeral joint space is what we're going to be measuring in a couple of slides from now. So at this level, the ulnar humeral joint space was measured both at rest, and then we apply stress. So how do we measure that? We put the electronic calipers in the bony cortex of the humeral trochlea and the ulnar coracoid, ulnar coronary process, just like it's shown in this image, and the machine gave us a measurement right around there. Now, once we had a good image of what rest looked like, then we began applying stress. And this is really where we had to dissect down the prior literature, because this is where we saw the biggest variation on their study methodology from before. One of the first studies actually just used gravity at rest, and that's what they quantify as vagus stress. Lee and all in 1998 used 5-pound weight at the wrist, and that was what they used as vagus stress. Not really very reproducible. Dr. Nasserian in 2003 did one of the best studies, first studies on MLB pitchers, where he began ultrasounding them in spring training, and he had the head team trainer apply vagus force. Again, not very reproducible. Another studies came out with using the TLOS machine that actually applied a force, but is a big machine, not a practical thing to use in office. So what we decided to do is standardize our vagus stress by putting vagus torque at minimum of 25 newtons with the same distance from the elbow, and we did this with a handheld dynamometer, just like Dr. Hack was showing here in this image. This is the machine. And at this point, we apply vagus stress. Then a video clip was recorded and then played back until we reached maximum ulnar humeral joint space gapping. Distance was then recorded, and here I have a clip of exactly what that would look like. Yep. So again, this is an intact UCL. UCL is coming from here to here. This is the ulnar humeral space. Very minimal gapping, as you would expect in an intact UCL. But if you see here, as we change the intra-articular pressure, there's a little bit of fluid coming in and out, and you're actually able to see the gapping. Now, at this point, the images were measured. We have here on the top image, a image at rest, 0.35. This machine is giving it to us in centimeters, so if we move the decimal point, at rest is 3.5 millimeters. Once we calculated the maximum ulnar humeral gapping, in this particular subject, it was 3.9. We subtract stress versus rest. This particular subject had a gapping difference of 0.4 millimeter, less than half a millimeter. Now, once we finished the study at 30 degrees, then we did the same thing at 70 degrees, and then we repeated the same scan with the contralateral elbow. The first day, every subject was scanned by both of our physicians, and we used that data to quantify inter-rater accuracy, which means how far were our scans when done by two different physicians, and then the same subject was brought back at a different date and had the same scan performed by one of our physicians, and we used that data to quantify intra-rater, where how far were the same physicians doing the same protocol at different dates. So this is what we got on our results, and I just want to show you guys because we were very excited of what we found. Our mean gapping, about half a millimeter, just like in the prior video that I showed. When we look at how far were we, our standard error of measurement, when we looked at 30 degrees, 0.1 millimeter. That's 1/10 of a millimeter, which how far were our physicians day one versus day two. Our mean differences, again, minuscule numbers, 0.7. Mean differences is really actually the difference of means. In the statistical world, this is the same thing as accuracy. So extremely accurate. But what about inter-rater between physicians? Very small numbers as well. What about at 70 degrees? Does it change? Not really. The same. We saw the numbers throughout the whole scan. Mean gapping was very similar, half a millimeter throughout. And our standard error of measurement, both for intra-rater and inter-rater, were minuscule, significantly small. What about at the contralateral elbow? Same thing. So you guys could see the numbers here. What about a 7? Pretty much throughout the board. So in our discussions, in conclusion, we noticed that the mean ulnohumeral gapping averages were similar, both at 30 degrees and at 70 degrees, and it didn't really change with the contralateral elbow. Now, it's important to mention that our subjects were non-pitchers, because we know that pitchers are, let me take this out of here, pitchers are in a different realm. Our standard error of measurement and our mean differences were, again, very small, minuscule, and our study was extremely accurate. We also noticed that maximum physiologic valgus gap was always seen at a minimum of 20 newtons of torque at the elbow. And to finish off, dynamic ultrasound assessment of the UCL is an extremely precise and accurate study that should be considered when evaluating for UCL injuries. Thank you. Any questions?
Go back and teach us something.
Go ahead.
For those of us that still have a lot of trouble, show us the first ultrasound that you said was the ligament.
Okay.